South Africa expresses sincere appreciation to the Better Health Programme, and as you stated, Vimla, as part of the wider UK Prosperity Fund, and which is delivered by Mott MacDonald. It is highly commendable that you aim to support partner countries with health systems reforms with the goal of expanding universal health coverage, which so often NCDs is ignored, and improving health and related economic growth outcomes. And we are acutely aware of the relationship between health and especially health outcomes with regard to NCDs and development. And in line with the multi-country program, we concur with the primary objectives, which you've also highlighted, and that is strengthen health system structures and workforce capacity to address the burden of NCDs, as well as strengthen structures, processes, governance, regulation, and capabilities to create systematic mechanisms to drive improvements. While noting that Better Health Program SA works closely with the National Department of Health to ensure that our priorities are aligned, and that you've worked with partners on 5 focus areas, including NCDs. We also in NCDs recognize that these 5 areas have implications which are cross-cutting, and all areas will ultimately benefit NCD outcomes. And these, as you've mentioned, include NCDs, quality improvement and quality assurance, strategic mechanism and processes to support universal health coverage, oversight and accountability, and digital health informations. And as I've stated, we cannot separate all 5 issues from NCDs, and all of them contribute to better NCD outcomes. Your comprehensive support during year 1 was groundbreaking as the country struggled against the COVID-19 pandemic, which revealed the serious gaps in our health systems to effectively respond to persons living with NCDs and who were at risk for serious COVID-19 illness, and as we know, many passed. However, you continue to offer technical support toward the finalization of the NSP and technical inputs related to the implementation of the NCD policy, which we envisage will contribute to our journey towards meeting the SDG target 3.4. We look forward to the 4 reports that you will be presenting, as well as the networking between all the partners towards an improved, stronger, and better quality NCD service delivery platform. It is within this context that we look forward to working with you moving towards year 2, and it gives me great pleasure to handing over to the authors of your reports as we move forward. Thank you very much.
Thank you, Sandhya. Can we move on to the next slide, please? We have our first presentation by Adrian on the multi-sectoral approaches and standalone strategies. Adrian.
Thank you, Vimla, and thank you, everybody. It's nice to be here with you. My name's Adrienne Chatto-Brown, and I'm a member of the Mott team based in the UK, and I'm the lead specialist for health systems and service delivery. And I worked on these 2 assignments along with my colleague, Kaylee Miller. Say hello, Kaylee.
Hello, everyone.
Thank you. The first one I'm going to present to you is the multi-sectoral and multi-stakeholder approaches to tackling NCDs, where we looked at lessons from implementation from other countries and other health issues, not just non-communicable diseases. So we have a series of recommendations that we're going to present to you now. And the first one is the key recommendation, which is to engage beyond the health sector, both within government and outside of government with other stakeholders. And the rationale for this is because NCDs arise from many factors which are outside the control of the health sector alone, and therefore logically the health sector on its own can't solve the NCD problem. The private sector is a very important vector for NCDs. When I say private sector, I mean industry and business producing things like fizzy drinks and tobacco, and we'll talk more about that in a minute. And therefore, it's very important that the private sector is brought on board as far as possible. And also, it's very evident from experiences elsewhere that other stakeholders potentially bring many strengths to the fight against NCDs, and they also provide opportunities. So they're very important partners. Obviously, NDOH should aim to work with the wider South African government because it has many potential functions as both a regulator and a catalyst, which can help shape the national NCD effort and also shape stakeholder involvement. As I said briefly, NDOH will also need to engage with non-state actors such as the private sector, business, industry, large scale, small scale, national and multinational. And NDOH should also engage with civil society. We define civil society quite broadly. We included NGOs, CSOs, academia and research organisations. I'm not going to go into this slide in detail because this summarises quite a large section of the report, but I think suffice it to say that, as you can see here, other stakeholders bring many benefits such as policy coherence, regulation, advocacy, resources, and so on. What I would draw your attention to is that bubble in the top right-hand corner attached to the private sector, which notes that whilst the private sector brings many benefits, working with the private sector also brings challenges. And these challenges largely arise because for many private sector organisations, the actual reason for existence is to produce products and services that actually damage public health, that create non-communicable diseases. And also that many of them are very powerful, particularly the multinationals. And added together, this means that they are very challenging stakeholders to work with. And a lot of our recommendations are largely about how to broker relationships and manage power with the private sector because they're so challenging. Civil society and other government sectors bring their challenges, but they are more straightforward. So our second group of recommendations is about establishing national coordination mechanisms, and you've clearly given a lot of thought to this. And we took the work that you had done as a starting point for thinking through further about how this could be progressed. And these national coordination mechanisms both need to be with other sectors and with these different stakeholders that we just looked at a moment ago. A key step is to really systematically consider those different stakeholder characteristics, motivations, and mutual dependencies. The reason for this is that different types of stakeholders are clearly very different, and therefore you may need to engage them in different ways. It's also very important that you focus not just on what's to be achieved, but how it's to be achieved. And a key step to doing this is to make very deliberate efforts to build trust, ensure transparency, and share information and knowledge. And this needs to be underpinned by a measured, step-by-step approach to developing lasting, well-managed, and coherent institutional frameworks. So I think this can be summed up by it being important to pay attention to not just outcomes of the coordination mechanisms, but also the processes by which they work. And a key finding was the importance of high-level political support to make those processes effective. So the lesson is that high-level political support sitting above sectors can help to manage conflict of interest. And we'll talk more about conflict of interest. Now, in your NSP, you talk about one mechanism. In fact, I think in practice that what needs to happen is that you need a series of different mechanisms. I'm going to turn my camera off for a moment because I can see my image is frozen, and it might be that there are bandwidth issues. So I'm just turning it off for the moment. So you have one mechanism identified, but in fact what you probably need is a range of different mechanisms across different issues and groups of stakeholders. And we summarize these under different characteristics. And at one end of the spectrum is consultation. So, for example, community consultations on particular issues and periodic consultation fora. And at the other end of the spectrum is partnership, interministerial committees and provincial councils being one example. And partnership obviously gives stakeholders a lot more power than just consultation, where you just speak to them to find out their views. And this spectrum has benefits, but it also has challenges. So you need to think through very carefully about how much power you want to give stakeholders, and also what you're prepared to manage, because the consultation end of the spectrum is easier to manage, but it does give you less power, does give the stakeholders less power. At the partnership end, there's more power for stakeholders, but on the other hand, it's more complicated to manage. Our third group of recommendations is about undertaking common planning to develop lower level operational plans. You've got a national plan, but we recommend that you use this to develop plans with those at the lower levels who are actually going to be implementing the NSP. And these plans need to be developed jointly with all stakeholders to create common vision and a common understanding of the problems and causes. It's very important when you're doing this to rely on good quality data, because this can generate evidence which can inform those plans. It also gives a sense of feasibility, and it can identify mutual benefits to stakeholders. And when stakeholders understand benefits, they will be motivated to engage. And of course, good quality data also underpins monitoring and evaluation. Let me see if I can get the video working again. No, I don't think so. Okay. It's important, as we can see from the evidence in other countries, to base these lower level operational plans on actual available capacity, on realistic costing, and on existing resources. One of the pieces of evidence we looked at was a study carried out in southeastern Europe on an intersectoral collaboration to tackle NCDs. And the main reason for failure was that strategies didn't have sufficient resources, either human resources or financial resources, to actually put them into practice. It's important that you take the advantage of existing collaborative efforts. You don't need to start from scratch. There are probably many mechanisms, many arrangements, many partnerships and relationships that you can build on. Not just in the health sector, but from all other sectors, other initiatives. It's also important to be opportunistic and flexible to get short-term wins. It's great to have long-term goals, but short-term wins, short-term, preferably easy wins, mobilize everybody and act as a great motivator and give a sense that success is at hand. It's also important to define concrete and measurable steps towards achieving objectives. Steps along the way, so that you're not just aiming at one enormous goal, you've got defined success points. Again, this is good for motivation. Our next key recommendation is to proactively manage conflict of interest with the private sector. On that earlier slide, I flagged up the challenges of working with the private sector because of essentially a conflict of interest in what they want to achieve and what you as a public health organisation wishes to achieve. So the most important message that came out of all the literature and the experience from other countries is, first of all, to be realistic about whether conflict of interest can actually be managed. And in some cases, it's just not possible. It's difficult at the partnership end of the spectrum, which I showed you earlier. And there are many examples of where governments, departments like yourself, have tried to form a partnership with organisations that simply have no interest in supporting the work that they do. And there's a salutary lesson to be learned from the Philippines that Kaylee explains in the report, and I would encourage you to read that, working with the tobacco industry. But I know South Africa has also had challenging experiences with the tobacco industry. So in order to establish whether it's feasible to work with organisations like this, there needs to be a systematic approach to assessing conflict of interest. And in the report, we present a flowchart and some possible issues to be considered. And this is based on a document that was developed by WHO actually to assess conflict of interest in the nutrition sector. But I think it's worth having a look at it and seeing how you can adapt it for your own use, because I think it's very relevant. Other lessons learned from the literature in other countries is that it's very important to ensure the independence of government. And this means building capacity of you and your colleagues to actually manage conflict of interest, to understand what it is, to understand what the pressures are likely to be, and to establish some ground rules for how conflict of interest should be dealt with, in order to make sure that it is doesn't get out of hand. So, for example, making sure that if in a public hearing or discussion or one of the consultation fora that we talked about earlier, that there's no expectation that you should act on any of the views or engage in debate with the parties that are there. You don't have to do that. And as a lead agency, you retain the right of approval of everything, of plans and so on, and policies, obviously, but it's very important to keep asserting that. Part of the strategy can be developing transparent approaches to managing conflict of interest and getting stakeholders to sign up to them. So, for example, your coordination mechanisms could benefit from having terms of reference and assigning roles and specific contributions so that stakeholders know exactly what's expected of them from the outset. And you've already done some preliminary work in this in the NSP. And finally, it's helpful to have independent monitoring and evaluation processes to assess progress and contribution, because this will help you monitor both the final result, but also steer the partnerships, the stakeholder engagement arrangements, and manage conflict of interest as you go along. Our next group of recommendations focuses on developing accountability mechanisms, which are very tied into conflict of interest, as I just discussed. And it's quite possible you already have existing accountabilities across government. Perhaps an audit of these might be useful to see how they could be adapted and to discover where you need new ones. As I mentioned before, establishing responsibilities with stakeholders up front can be helpful, and this will take negotiation within your coordination mechanisms to establish exactly what contributions are expected so that you can hold them to account for those contributions. And as I said, it helps to be clear about which organisations are responsible for which activities, and to specify financial commitments, timelines, and expected results for individual organisations. And between you, you can decide on how joint success is to be measured and attributed. And again, that will help people along the way. It'll give you standards to achieve from the outset. And I come back to my earlier point about considering whether higher level leadership and higher level political support above NDOH could help ensure accountability from other sectors. Now, obviously, NDOH, you're not going to be able to do all this by yourself. There are going to have to be local coordination mechanisms. And you have done some preliminary thinking about these in the NSP. And you've clearly learnt from your experience in HIV and elsewhere. Now, we looked at the literature in HIV and other countries and NCDs and other diseases to pull out some lessons for you. And a key learning point was that it's very important to make sure that local coordination mechanisms have sufficient powers and resources to function properly. So they need to be designed to enable meaningful participation. And members of those lower level coordination mechanisms also need to be engaged in priority setting to ensure the relevance of targets and the effectiveness of strategies. And you might need to build their capacity to enable them to do this, because this can be quite challenging. And it's a key lesson that a lack of local capacity undermined the effectiveness of implementation of NCD strategic plans in other countries. And don't forget that obviously there's going to need to be processes for collaboration between national coordination mechanisms. And common pitfalls are a lack of communication, a lack of clarity on roles, and challenges with policy coherence. And our final recommendation, group of recommendations, is around monitoring programme implementation and impact. And I've touched on some of these already. We looked at your monitoring framework, and we would really recommend that you assess. Now, I'm not sure if we saw the very final version. I'm sure there's a more recent version, but it's worth revisiting it just to make sure that it's complete with targets and output indicators and activities and lead agencies identified for each strategic objective. And also to ensure that it's clear how targets at all levels contribute to the hierarchy of achievements expected. And this is an area where you can engage stakeholders on this further development of the monitoring framework. And it's important to monitor not just results, but also multi-sectoral and multi-stakeholder engagement. As I said earlier, look at the processes, not just the outcomes. And this monitoring process needs to operate both horizontally at national level, for example, but also vertically, engaging your lower level coordination mechanisms so that all stakeholders are engaged and informed. And again, independent monitoring is useful and really recommended where it's at all possible. That's the end of our presentation on the multi-sectoral, multi-stakeholder strategies. I'm going to talk briefly now about the work that we did on reviewing the alignment of individual NCD and other strategies against the draft NSP. And we addressed two different types of strategies, which we characterised as standalone NCD strategies, and these directly addressed risk factors or NCDs themselves. So the National Cancer Strategic Framework is one example of those. And we also reviewed what we called overlapping strategies, which could be expected to address NCDs, but not exclusively. So, for example, strategies to address the needs of population groups, operational service delivery strategies, and communicable disease strategies. And we looked at the NSP and we asked the question, where should all these strategies align? And we came up with a list, which I won't go through here because these will be familiar to you as authors of the NSP. But you'll see that we went through it systematically, and then I and my team did a systematic assessment of each of the strategies against each of these points of alignment. Now, I should add a caveat that timing meant that the NSP had already been written. The NSP was written after all these strategies were written, and I think therefore one shouldn't have too many expectations about how well they align, but it's clearly still worth asking the questions. So we've put up a graphic here which briefly summarises how well the standalone strategies align to the NSP, and as you can see, it's a very mixed picture, that in some cases they did well, they were closely aligned, but in others they weren't, and some strategies were good in some places and not in others. And we also did the same exercise with the overlapping strategies, and again you can see a mixed picture, but rather more red on this slide. But again, that's perhaps not surprising given that they were only overlapping, they're not directly aligned. Now, we've got a group of recommendations for all strategies, and then some recommendations which I'll go through briefly for the different groups of strategy. And the first one, which applies to all strategies, is that it's very important that the NSP is being recognised as having strategic primacy over the lower level strategies when it comes to NCDs. we would question, would rather challenge you to consider whether the organisational structure of NDOH enables this. Does it ensure a consolidated and coherent structure for NCD implementation? And does it enable systematic monitoring and reporting of collective policies and programmes that contribute to NCDs? All this is important because it enables you to corral all these lower level strategies and activities. There are quite a few lower level strategies that are missing, and there's a graphic in the report to show you where some of the gaps are and where they need to be filled in. It's also important to consider whether the strategies of the NSP and the associated strategies are realistic, because there's quite a lot of blue sky thinking in the lower level strategies, and it's difficult to see how they contribute directly to the NSP. And what would really help this would be developing the national monitoring framework into a robust M&E plan, and I believe that is your intention. And this needs to be based on shared indicators across all strategies to enable common monitoring. So in terms of recommendations for the standalone strategies, this is where I think you can be most robust, and it would be very helpful to have guidance that can be used by the authors of new strategies and when they're revising strategies. And things that will help would be a common structure and a very clear articulation of where the points of alignment should be. What are your expectations of these lower level strategies, including arrangements of implementation and coordination arrangements, because they differed quite a lot. And you should very clearly require alignment with the strategic objectives of the NSP and the targets and so on. And you should also require alignment with the implementation plans and yearly targets. There needs to be clearer resourcing. And this, I think, also means that the lower level strategies are going to need help with priority setting in line with the NSP. And what's missing from many of the strategies is a multi-sectoral, multi-stakeholder approach, which is fundamental to the NSP but doesn't appear in those strategies. Now, in terms of the overlapping strategies, the recommendations are very similar, but I think your expectations need to be a bit lower because those strategies have a different focus. So they will also need guidance in which you could, for example, seek an explanation of how inputs in those strategies can address NCDs. Again, it will be helpful for you to articulate where the points of alignment should be, and also to explore how coordination and implementation mechanisms can support NCD interventions. And you should encourage strategies to pick up on relevant NSP strategic objectives and so on. And finally, encourage individual strategies to make it clear how they're contributing to the detailed implementation plans of the NSP. Thank you. That's the end of my presentation.
Thank you very much, Adrian. We can now move on to the next presentation, which is SBCC to prevent NCDs. This will be presented by Sarah. Thank you, Sarah.
Thanks and good morning to everyone. Before I begin, I would also just like to acknowledge that this work was done as part of a team, and I had two colleagues, Dr. Noblembu Mwanda Motwadi, who is here, so welcome Nob, and also Matata Diomande. So welcome to everyone, and the work I am going to be presenting this morning relates to two different pieces of work, which were around social and behavior change communication, which I'll be calling SBCC, to prevent NCDs. And there were two reports that are linked to this. One is called the Key Components document, and then we did an evaluation of the National Nutrition and Obesity Week. Let me just move through. So I'm starting now with the work that we did around an SBCC strategy for NCD prevention. And the purpose of this work was really to provide a basis for the development of a detailed strategy that would be aligned to the NSP, which was still in draft form last year. So one of the objectives was to introduce what we call key components that are required for any SBCC strategy. So much like Adrian was saying, it would be helpful to have sort of a common format for all strategies. That is the first piece of the work that we were doing to say what ought to be part of any SBCC strategy. The second was that we conducted as a team very specific work looking at what could be done for primary prevention of NCDs in the South African context. So to do this, we looked at the draft NSP, but we also drew on both international and context-specific evidence to give examples and ideas of how we might look at an SBCC strategy aligned to the NSP. And finally, the third objective was to model the process of planning an SBCC strategy using that evidence. So we gave lots of examples. Because the draft wasn't yet finished for the NSP, this was more modeling what could be done as opposed to providing a prescriptive SBCC strategy before the NSP was finalized. And sorry, finally, we provided a list of recommendations, which I will be going through in a bit more detail just now. So because our scope was looking just at the prevention of NCDs and not control and management, we decided to look at the evidence for which of the risk factors are most modifiable or changeable, and elected to look at the 4 main risk behaviors, behavioral risk factors for NCDs, which were smoking, unhealthy diet, physical inactivity, and harmful drinking. Although our report also does discuss air pollution and occupational exposures as also being important. And then with regards to SBCC, for those who might not be familiar with this term, we spent quite a bit of time and space in the document defining what would be considered the standards for quality social and behavior change communication. In particular, ensuring that when we look at things like NCDs, we think not only of the individuals who are placed at highest risk, who have the highest burden of disease, but also the contexts in which that becomes the case, whether that is interpersonal, community, or at the high policy levels. And so what you see here in this slide is a list of the different quality standards that we go into and explain in quite a bit of detail about the importance of having a planned process for understanding what the context is, ensuring that what we do when we prioritize is evidence-based in that context. We talk about theory and proposed theory in terms of how to bring about change. We talk about different audience insights and how to segment. Also, in the last presentation, we heard about objectives, but in the communication strategy, there's something that goes beyond sort of programmatic objectives, which is called communication objectives. So we talk through that and talk about how those are created, and then propose a number of different strategic approaches that have worked based on evidence in other contexts and even in South Africa that could be considered to operationalize the NSP. We talk through participatory approaches. We do touch on in quite a bit of detail some ideas around multi-sectoral action, as well as the importance of gender equity and social inclusion in this work, the avoidance of stigmatization, and also the importance in NCDs of applying a life course approach. Whoops, excuse me. So to develop this, as I mentioned, we did quite a lot of desk review looking at best buys, but also additional evidence. And then we consulted with a number of representatives from government, civil society, research institutions, including an advisory group to help come up with our suggestions and recommendations. What resulted is quite a long document, which you'll all have access to. And the document structure and recommendations have both what I would call sort of generic recommendations around what you see in blue, like key SBCC components, common problems and solutions when applying SBCC solutions, and M&E considerations, but also has a number of evidence-based research that was conducted around NCDs globally in South Africa, SBCC campaigns, both globally and in South Africa. And then we model how one could think about alignment with the NSP and other policies, and how we could go through modeling for these 4 different risk behaviors, the identification of audiences, potential communication objectives and approaches that could be used, as well as M&E potential indicators that could be considered. As I mentioned, a limitation was that the NSP was still in draft format. So we came up with a number of recommendations for alignment as the NSP is finalized in this year. And so again, these recommendations you see here, there's 7 recommendations. The first was that any strategy around communication should be fully aligned to support the NSP. So the NSP should take primacy. And the idea of the SBCC strategy is really then just to provide further details and indicators of how one could go about doing that. The importance of process, I think Adrian spoke a lot about this, is very important to identify early on, which is linked to clarifying the roles of different stakeholders in the design stage, as well as that critical factor of resources. How will this be funded? Through which mechanisms? And that part of that process early on needs to include consideration of gender equity and social inclusion. It can't be an afterthought. Then again, a very specific recommendation that an NSP will never be able to deliver on, but it comes from the NSP, would be the development of communication objectives that are audience specific, that are also based on evidence for South Africa. And the report goes into great detail about that. And then alignment with approaches that link to those objectives and audiences. So there should be sort of a coherent picture that is put together in this strategy. Something that we reflected on a lot last year was the potential of disruptions, such as COVID-19, to ongoing plans and strategies. So we actually create a section in the report where we talk about some ways to think about planning for disruption and how to mitigate the impact of those disruptions on meeting our objectives. And then finally, our feeling was that because the timing was a little bit off, that the document could be used most definitely, we think, by the National Department of Health in thinking through how to operationalize the NSP for NCDs, but also the document may be useful to other stakeholders, including civil society, who might be working on one of those different risk factors, or maybe multiple of the risk factors, as they think through how to prioritize what they're doing. So that is the first report. It's quite a long one, but we encourage people to take a look at it. A lot of work went into it. And the key contributions really of that report, we believe, are the evidence-based recommendations that are very specific to NCD prevention. We also created a quality assurance tool, which allows for any kind of campaign, but specifically an NCD campaign, to be reviewed to see if those principles, the key components, are being adhered to. There was an M&E performance framework that was proposed that could be used as a starting base for M&E, as well as a theory of change, which again could be adapted based on the final version. So that quality assurance tool I spoke about in the previous report was then used and piloted to evaluate a National Nutrition and Obesity Week campaign that is coordinated by the Nutrition Directorate. And I'd like to welcome our colleagues. I see they're on the call, Rebone and Modi. And this evaluation was to look at the campaign and whether it had the institutional support and the degree to which it adhered to the SBCC quality standards that I mentioned previously. So the objectives of this evaluation were, one side was to quantify the degree to which the campaign met the contextual support and quality standards that were set out. And this was a self-assessment based on a tool. The next thing was to look at qualitatively how the campaign was planned, designed, implemented, monitored, and evaluated using that SBCC lens. So this campaign wasn't designed as an SBCC campaign, but using that lens, we wanted to identify where there might be opportunities And the final, as I just mentioned, was to identify opportunities in the future, as this is an annual campaign, look for opportunities that could draw on SBCC practice to improve upon what happened in 2020. So the process to do this was that we conducted, again as a team, 8 interviews with 7 different key informants using a structured tool that has been used in other contexts as well, in Malawi and in South Africa with the Health Promotion Department. And so we had interviews that were facilitated where there was self-scoring. In addition to that, we asked for documents from the campaign, both planning documents, background documents, and the actual materials that they used in the campaign for reviewing and commenting. And then we allowed a back and forth. So there were opportunities throughout the process for people who were involved in the campaign to provide inputs or clarification. So the documents we looked at were things like the strategies that the NDOH uses, organograms, budgets to give a picture of the institutional background. We looked at the specific campaign-specific planning documents, like a concept note and their strategy, their materials, as well as the reports that followed the implementation of the campaign. So the limitations I wanted to mention before was that this wasn't instituted as an SBCC strategy, though we used a lens, so it's to be expected that they might not have ticked all those boxes. Also, there was only 1 month allowed for data collection, so it was a limited time to consult, and because of that, we didn't get a full comprehensive opportunity to see all of the materials or talk to all of the key people that were there. So we do want to acknowledge that limitation. However, I think we did learn some really important and interesting things about this campaign. Here you'll see the quantitative results, which they were scored out of 4, 4 being that the best score. So institutional systems, for example, are 100% in line with the SBCC principles. And then, of course, lower, less aligned. And what you can see here is, in terms of the self-assessment, there is a context which is open to and supportive of SBCC practice. However, when it comes to the implementation, from the planning and design part to implementing a campaign or evaluating it, the self-assessments were a little bit lower. And the report details this in great detail. So if you're interested, you can look at the basis for these different scores. Here, I just want to mention a couple points. And the first is that in terms of the strength, again, the Nutrition Directorate has a very strong mandate for the work that they're doing. And they've also been very successful at bringing together a broad range of stakeholders to coordinate a communicated and to coordinate this campaign. And they had a strategy. And those stakeholders were reputable experts and organizations. And they had a strong commitment to the quality and accuracy of messages. And those messages, even in the context of COVID-19, were clearly branded. They were very professional, and they used a range of formats from print to social media, visuals, and audio. They also, in terms of gender, were able to challenge some harmful gender stereotypes. For instance, they were able to show a young man cooking. And also there was an awareness of stigmatization, and they worked hard to make sure materials were not stigmatizing populations, for instance, around body shaming, as an example. However, we did have recommendations, particularly for planning and designing. There were some potential gaps that could be added to, for example, in the situational analysis. More could be done to understand different audiences and how they use communication, what they listen to, how they engage with communication channels to better reach those people. There wasn't a clear theory of change, of how activities are expected to change outcomes or behaviors. So that is something that could be added. There were objectives, but not necessarily what we would consider smart communication objectives, nor was there a distinct M&E plan, which we felt like, again, would have added rigor to the planning process. There wasn't a specific campaign budget, and so there was a lot of reliance on partners or stakeholders to be able to come up with resources to pull it together, which they managed to do, but a specific budget would be helpful. And then in terms of process, Adrian had mentioned conflicts of interest. There was concern raised around having a formalized system to avoid any conflicts of interest with the different stakeholders. A call for earlier delegation of roles and working groups to facilitate earlier planning and decision making, and also a call to pre-test materials, not just with technical experts, but with audiences. I'm just going to go through the last two slides very quickly. The other recommendations around implementation was that there wasn't a centralized implementation plan. So there were lots of messages created, but during the actual weeks of the campaign, it wasn't always planned out or plotted centrally. Different stakeholders did what they did. This could be addressed by designating a campaign coordinator or someone to help support the directorate staff to oversee this. That would also be supported, of course, by an M&E plan, like we mentioned before. And having a common monitoring tool would support stakeholders to provide common reports after the fact also of what they were doing. So this could be done by enlisting M&E experts or partnering with academia to help support some of these pieces around M&E. And then linked to evaluation, as I mentioned, there wasn't internal capacity necessarily to do this type of M&E, but partnerships could be supportive here. There also is scope to have evaluation questions that could be shared with research institutions or academics who could take on a piece of that to help the program and the campaign learn moving forward. There are different evaluation designs that are amenable to such short campaigns that could be looked at. And then developing templates, again, that would help systematize the understanding of this campaign could help learn year on year, especially at lower levels, such as the provincial levels, where a lot of the work was being done. And that's the end for us. We hope you look at our reports and can engage with that further. Thanks very much. I'll now hand it over to Claire.
Good morning, everyone. Can you guys hear me?
Yep, fine.
Thanks very much, Claire. Please go ahead.
Thank you. My name is Claire Botha. I'm with the Autumn Institute, and I'm working on the Better Health program as a sub-consultant. Our presentation, there are two parts to it. I will be looking or presenting on the situation analysis that was conducted, and my colleague Linda will touch on or present on the NCD surveillance system.
Thank you, Claire. Please go ahead.
Okay. First of all, the purpose of the situation analysis was to analyze the current state of NCD data within the South African context. This effort consisted of three major interrelated tasks. So first of all, there was a review of the National Strategic Plan for Non-Communicable Diseases. This was also then followed by a review on the current NCD data set within the National Indicator Data Set. And then finally, I will be presenting on the review of the data sources. Okay, in reviewing the National Strategic Plan, it's important to understand the NCD ecosystem within which it is located. The ecosystem can be thought of as consisting of two contexts, a global context and a national context. The National Strategic Plan clearly operates in the national context. However, it draws on the global context for guidance and justification. The global context consists of, as you can see, the Global Action Plan and the Global Monitoring Framework. The Global Action Plan provides a roadmap that countries can follow in developing their own strategic plans, but it also provides policy options that countries can choose from according to their own specific environments. The Global Monitoring Framework is more detailed, providing countries with a standard and specific set of NCD indicators that can be or should be monitored. Now, this standardization is important because it will enable the WHO to do country-to-country comparisons. But having said that, it doesn't necessarily mean that countries cannot have their own or add their own indication in addition to the WHO's. As you can see, the National Strategic Plan here aligns with the Global Action Plan on a policy level, and the strategic framework aligns with the Global Monitoring Framework. The implementation plan, as you all know, will deal with things like who, what, when, and where. The final element in this ecosystem is the NIDS, which is a repository containing the national indicator data set. Now, this repository provides standard definitions for the indicators and the data elements, which is essential to ensure consistency in the collection, analysis, and interpretation and reporting of the indicators. But more importantly, I think it serves as a single reference when conducting the evaluations. With regards to the review of the National Strategic Plan, a pre-implementation review was conducted, right? And this is where we are. That was a review of the strategic plan before its implementation. A pre-implementation review by its nature is foresighted in terms of it predicting the future successes and the failures based on the indicators that's embedded in the plan itself and the context within which it is drafted. A useful way of looking at the indicators is to categorize them into leading and lagging indicators. Leading indicators are considered the input indicators, which, depending on how you are about to address it, can determine the credibility of the plan. On the other hand, the lagging indicators are performance-based indicators. These are indicators that is listed in the strategic framework along with its related objectives and targets. And these are also indicators which the Department of Health has more direct control of. While some attention is given to the leading indicators in the situation analysis document, our presentation here will focus on the lagging indicators. Maybe just to add, while the leading indicators speak to the credibility of the plan, it is the lagging indicator that speaks to its achievability. Just in terms of the review and how it was done, the indicators for each objective, and there are 7 objectives in the strategic plan, was assessed using 3 criteria. And these were the output validity, whether the outputs contribute towards achieving the objective. The second criteria, the activity relevance, whether the activities will produce the outputs. And the third criteria, the indicator measurability. That links to or relates to whether the indicator is a valid metric for the objective. Also, each indicator was then rated using the following description. The rating that was applied was weak, moderate, and strong. With weak, the description there, it is whether the indicator is a valid metric for the objective. Moderate was whether the indicator is somewhat valid, but it has some deficiencies. And strong was in reference to the indicator being a good metric for the objective or the output. Just in terms of the results, with regards to the indicator measurability, what we found is that 50% of the 103 indicators that were listed in the strategic plan were found to be strong metrics for the expected outputs or the relevant objective. Also, we found that 17% were found to be moderate, while 34% were considered to be weak. Therefore, in conclusion, it is a significant portion of the indicators is either weak or moderate and has serious implications for the credibility of the assessment on which it is based. With regards to the activity relevance, we found that most of the activities will result in the expected outputs that it needs to produce, and that was about 64%. However, a significant portion will not be achieved in terms of achieving the expected outputs, which could undermine the implementation. However, this can be addressed by either revisiting the planned activities or redefining the expected outputs to achieve in order to achieve better alignment. With regards to the review of the current NCD data set, this was what we found. The review of the NCD data set is based on two instruments, namely the Global Monitoring Framework and the National Strategic Framework. So what we did, the National Strategic Framework was compared to the WHO Global Monitoring Framework, which served as the standard to determine whether the prescribed indicators are reflected in the National Strategic Framework. That is in terms of its completeness. Furthermore, the data set in the NIDS, that's a National Indicator Data Set, was compared again to the National Strategic Framework also for completeness. And finally, the data set in the NIDS was compared to the Global Monitoring Framework for compliance, i.e. comparing the prescribed Global Monitoring Framework indicator format with the indicator format of the NIDS to determine whether the NIDS align with the formats specified in the Global Monitoring Framework. Okay, what we have here or show here is a presentation on the outcomes. The table here compares the Global Monitoring Framework, the National Strategic Framework, and the NIDS in terms of the number of indicators with relevance to its completeness and the number of fields with regards to its compliance. The National Strategic Framework, as I pointed out earlier, contains 103 indicators. And therefore, in terms of the prescribed indicators, it contains 96% of the prescribed indicators that's listed in the Global Monitoring Framework. The NIDS contain 4 NCD-related indicators, but none or 0 prescribed indicators. Whereas the strategic framework is fairly compliant with the Global Monitoring Framework, the NIDS, however, is lagging behind. And this glaring gap is there, as you guys can see. So what is the implication of all of this for South Africa in terms of monitoring and evaluation? This means that it would be impossible to monitor and track and evaluate NCDs, right? So the question then is, why is it that the indicator count in the NIDS are so low? In my discussion with the program managers at the department for the NCD program, the following reasons were advanced. Number one, the organizational unit in the department limits the number of indicators programs are allowed to load on the NIDS, and that is due to capacity constraints. However, it's not clear in the capacity constraints challenge if it's systems or human resource constraints. Furthermore, the organizational unit that is responsible in managing the NIDS requires that programs meet certain predefined conditions before allowing them to load indicators onto the NIDS. This includes the existence of data collection tools, as well as strategies and guidelines, etc. So as you can see, all of this then places capacity demands on the very program that's supposed to do this. This slide presents, so here we look at a review of the data sources that was conducted as part of the situation analysis. So a review of existing data sources was done, which can be used to monitor NCDs. So what did this entail and how did we go about doing this? First of all, as a first step, we identified data sources that contain health information, okay? This was then followed up as part of the second step, that all these data sources which contain the health information was then split into 2 categories, electronic health records and non-electronic health records. To be considered an electronic health record, each record is described by clearly defined fields. It's electronically available, it can be retrieved electronically, it can be disaggregated, and it can be queried and further manipulated. On the other hand, a non-electronic record, as you all know, it's a paper-based record as opposed to an electronic record, but it is not so easily manipulated. And many a times, non-electronic records, as you know, are converted or have to be converted into electronic records for further manipulation and analysis. Thirdly, I looked at the frequency with which the data is collected. and two categories were identified. It's either regular or irregular. With regards to the regular, the data is updated at predefined intervals. With regards to irregular, here it's in reference to where data is maintained on an ad hoc basis. The data sources are maintained and not maintained on regular and predictable time intervals. As you can see here, so also from the data sources with regards to the review, if you drill down into each of these cells, you'll see a further distinction between a full record and a partial record. Full record is in reference to a data source that contained only health records, and partial is in reference to a data source that primarily does not necessarily contain only health information. Maybe an important point to point out here is that as part of the review of the existing data sources, I encountered that the National Department of Health is not necessarily the custodian of these data sources, which could have serious implications for the use of the data and to track the NCD indicators. Okay, as a final step in the analysis, an analysis was to create a table which contained a list of all the 25 prescribed indicators with their input parameters. Now, the input parameters are required to calculate the value of the indicator, okay? And the input parameters here, it's in reference to the method of calculation, the numerator and the denominator. The next step would then be to map the parameters to the data sources. That is, finding the appropriate data source that contains the information about the parameter. Although it wasn't done as part of this exercise or this assignment, this would require drilling down into each of the data sources to determine as to the extent it will satisfy this input parameter. Okay, finally, just with regards to overall findings and recommendations. The first finding with regards to the multi-sectoral coordination mechanism, Adrian touched on this quite extensively, but what we found is that the current structure responsible for driving the finalization of the NSP does not necessarily have a strong mandate. Okay, it could be argued that this is perhaps insignificant since it is envisaged that this structure, the old structure, will be replaced by a new structure, the NCD multi-sectoral coordination structure, which will have clearly defined roles and responsibilities. However, this structure could be further strengthened and formalized if it is established within the required legislation. And I think Section 91 of the Act of the Health Act makes provision for that. Also, Adrian and both Sarah touched on the participation of stakeholders, right? We found that the NSP is likely to fail if there's no way to ensure that the commitments that are made by all these participating stakeholders are followed through, right? The voluntary nature of the participation in the current structure is yet to be established, right? And yet to be established structure will lead to a weak decision-making, poor accountability, etc. So in order to ensure that these commitments are legally enforceable, it is recommended that the department consider entering into binding agreements with the various stakeholders, such as memorandum of understanding with regards to their roles, their commitments, and what's required of them. Okay. Another finding is that we found that the National Strategic Plan is not funded, although there's an understanding that it's funded through the equitable share mechanism. Now, the challenge here is that the assumption that the strategic plan is funded through the equitable share is misguided due to this disconnect between the activities in the NSP implementation plan and activities that's routinely carried out in the provinces. Provinces, for example, use the bulk of their equitable share to the health allocation to fund direct services. It is highly unlikely that the provinces will voluntarily set funding aside to carry out the activities that's contained in the National Strategic Plan, as this, from their point of view, will be viewed as an unfunded mandate. Thus, it is important that adequate resources, dedicated resources, are provided for the implementation of this strategic plan, and this could be done via the creation of a conditional grant. Also, we found that the activities of the NSP is not necessarily costed. And therefore, it's important that the NSP be costed and ideally using the conditional grant mechanism to create a cost center for that purpose. Okay. Also, what we found is that the National Strategic, or the NCD unit, or the program, sorry, is not established in terms of a program within the Department of Health, but currently it is a sub-program. And that speaks to its the level of priority that it is awarded within the program. Also, also we found that a significant portion of the indicators, as pointed out, is either weak or moderate, and a significant portion of those activities will not necessarily result in the expected outputs. So there is a need to revise the indicators in terms of finalizing the NSP plan, right? We also found that the indicators that's in the NITS is not necessarily the prescribed indicators that is required in terms of the WHO. It does contain, however, 4 NCD-related indicators. Right, and finally, the data required to track the 25 indicators we've discovered will reside on numerous systems, and it will be unlikely that you'll find all of these indicators in a single system. So we're therefore recommending that a system, an integrated system, be established for NCD surveillance. Thank you very much.
Thank you very much, Claire. Can we move on then to Linda? Linda?
Right. Good afternoon, everybody. My name's Linda Taylor, and I'm going to be presenting this on behalf of the whole GEMBI Health Systems team. Next slide, please. Thank you. So we worked very closely with Claire on all the work that she's just described around identifying data sources and data elements to contribute to the indicators. And really what our mandate was to look at this in the light of the ultimate goal, which is to come up with an integrated electronic national NCD surveillance system. And what we did was we did a desk-based landscape analysis and a very preliminary assessment in terms of really looking to see the current systems, particularly the ones with very successful track records, to really look at where those could be enhanced or extended in order to support the collection of NCD data. Next slide, please. So we started looking at the as-is, or the current state. And really 2 major findings came out of that, as Claire has elaborated on. And one is really the lack of electronic data available for NCDs to inform policymaking. But the other thing that came out quite strongly was also the lack of electronic data readily available actually within the facilities or within the community that was able to support the better provision of care. So electronic data still very limited in terms of most of it still being very much paper-based, and where it is in electronic form, coming from a multiple range of different data sources in very different formats and across very different timelines. And by comparison, we know that the health information systems for HIV and TB are much more advanced because they've had a lot of resources invested over the last 10 to 20 years. So what we really did then was start to look at those as a comparison. Next slide, please. Okay, so the other thing that we looked at again was the typical patient journey. And the thing that really came out of that from an information systems point of view is that the way that the patient and also the information progresses through the system is very similar in the sense that it follows the same sort of chronic care model as those for people living with HIV and TB. So really the recommendation that came out of that is to really learn the lessons that come out of implementing those HIV and TB information systems, and as much as possible to actually adapt and adopt and reuse those systems, both from reusing the actual software components, but also very much looking at the lessons learned and the sort of the patterns of use and the type of components that are in use. Next slide, please. The next thing that we really identified is what was the desired or the to-be state. And really the key to this is actually the interoperability of the system. So interoperability in terms of the way that you define your system architecture or your blueprint, as it were, for how to establish this. And really there are many levels of interoperability. So whether we're talking around structural interoperability, which is really that you have one computer system is able to exchange data with another computer system because they understand the content and the format in which they are exchanging data, whether it's because they're using the same standard or because we're using something that will actually transform that data into something that the receiving system can understand. Then there's also the semantic interoperability, which is really making sure that the information that is sent is received in the way that it is intended to be understood. So really we're talking here about the clinical terminologies and vocabularies. We're talking about things like the use of coding systems like ICD-10 or LOINC and so on. And then, of course, there's also the organizational interoperability, which really stresses the need for a strongly collaborative aspect to exchanging data. One of the other things that is critical is actually the use of a national unique patient identifier. And there we're really talking about the use of the health patient registration number, which is the national patient ID. So in terms of, you know, when you're establishing systems, being able to at least collect that and to be able to use that as a unique identifier, with the ultimate goal of actually being able to integrate with HPRS and to be able to perform lookups to validate that identifier and potentially even to get the IDs from that system. But without the use of a national unique patient identifier, it's not impossible, but it is much more complex to be able to integrate these data sources. The other very important identifier there is the master facility list that identifies facilities throughout the country. So to be able to ensure that you can collect those 6-digit facility codes. And then, of course, any information system really needs to align with those principles stated both in the National Digital Health Strategy and the National eHealth Strategy. And also, where possible, to be compliant within the HNSF, the Health Normative Standards Framework. And that really gives you the mechanisms, if you like, for how to do the structural and the semantic interoperability by making sure that systems are exchanging data in the same ways. Next slide, please. So in terms of possible solutions, again, as Claire alluded to, there is the national DHIS system already exists. It's a very well established system in those facilities that have connectivity. NCD indicators rather are already actually captured directly into Web DHIS, and there is a process already in place to be able to collect data and produce indicators. But we do know, again, as Claire mentioned, that there are some constraints around how many indicators and how much more data can be added to this existing system. So whilst that's still a very key part of any information system, the other thing that we actually looked at was the feasibility of actually using routine data already captured both within the facilities and at community level, and whether that could be leveraged and start to form part of the very early stages of this NCD surveillance system. And that's really for two things. And one is to also obviously to be able to collect and aggregate data to make it available for reporting at the various levels within the health system, but also equally to start to make that data much more available to the management and the clinicians and the community health workers right there at the point of care to be able to support that improved patient care. So just as there has been a move to, from the more disease-centric systems to a more holistic patient-centric model of care, so with the information systems, there's starting to be much more of an emphasis from systems that historically captured aggregate data and were very much focused on aggregate reporting, to systems that are also actually able to provide much more timely and accurate and complete data at the facility and at the community level. Next slide, please. So we considered potentially at the community level to the ability to actually use or extend those existing systems that are actually already collecting NCD data. For example, something like hypertension screening. And there are a number of existing tools actually already in use. We know that Comcare has a fairly well-established footprint in South Africa. We know that in the Western Cape, for example, Mabenzi Researcher is in use. And there are a wide number of tools that are fully capable of collecting a range of data and can be relatively easily adapted or extended to include additional NCD data elements. Next slide, please. Okay, equally at the facility level, I think that the key takeaway is really, as much as possible, to avoid multiple systems being introduced at the facility level, but really to try and extend and build on what's there already. And there it seemed that the obvious candidate was really to extend Tier.net, which already collects HIV and TB data, because it does have a very wide national footprint. It's been around for many years. People are very familiar with how to use it. And although it's typically data that is back entered, it does produce a lot of rich data that is fed up ultimately into the DHIS. So we did look in a fair bit of detail at Tier.net in terms of the feasibility, and it does seem very feasible to be able to extend it and collect additional data elements. I must just add, Tier.net is not an open source tool. We didn't look at the software code itself, but we do know from sort of informal discussions that this is something that is potentially very doable. Next slide, please. And then, of course, now that we're collecting all of these additional data elements, it needs to go somewhere. So really, now we're talking about setting up these backends or data centers to be able to store data from these multiple sources. And from within that, to be able to pull in lots of different data, as I say, in lots of different formats, but to perform sort of data cleaning and introduce some data science techniques to be able to produce visualizations and generate reports such as a cascade report. And in talking about this, there's some sort of key principles that we really wanted to recommend, which is, these systems by their very nature are very complex systems. And we did look very much at the Western Cape model. And we know that that's a complex system that's taken many years to get to the position where it is now. However, taking the learnings from that system, you can start with keeping it really as simple as possible. So designing for a very limited data set initially, maybe looking at just a couple of different data sources, and to design that bearing standards in mind, to build it, to implement it in a limited area, and then really to test and evaluate very strongly and to keep feeding into this very iterative cycle in order to make progress. So this is based very much around sort of software agile methodologies, which have gained a lot of traction over the last 10 to 15 years or so, because we know from much research that's been done that the old-fashioned waterfall way of developing and implementing systems actually really doesn't work very well at all. The number of IT systems or IT system projects that have failed is very high, and that has really driven this iterative process of design where you actually, the mantra is to actually fail early and fail often, because that's how you learn. So you start small with baby steps, but you start building, and you have a system architecture and standards framework that helps you to build that for the longer term. Next slide, please. So here's a diagram that really tries to elaborate what we're thinking in terms of a conceptual solution. So at this point, we're not even really talking specifically about software components or particular tools or particular technologies, but really what the system might ultimately look like. And you can see here, sitting at the heart of it, you have this central data repository, which might be one database, it might be multiple databases, it doesn't really matter. You have these different sources of data coming together within this broader health information exchange. So you will have tools sitting within there that actually allow for the data exchange and ensure that these different systems are able to talk to each other. And then what we've shown there is the possibility of having this NCD data captured through community health worker applications out in the field, and alternatively, or at the same time, data being captured at the facility within something like tier.net, feeding upwards into the central data repository, from which you are able to start drawing reports and visualizations. Okay, so whether you're talking about being able to view individual patient level data or aggregated at various levels, this gives you the possibility of actually doing both. Obviously very much bound within the structures of who is able to access which particular pieces of data. You'll see there too, what we have on the side is we've started to list some additional sources of data that could then actually be brought into that central data repository. And those are things like the population register that I mentioned earlier in terms of the unique patient identifier, and also things like lab data from NHLS or pharmacy data. So as this data starts to be pulled into the central data repository, so you start to be able to build up this longitudinal patient record, which you can then view, and you will be able to see a much more holistic view of the patient themselves, and also to have more complete and more detailed aggregate data. Next slide, please. Okay, so in terms of recommendations and next steps, one of the key things, and this really goes back to talking about the organizational interoperability, is really thinking around a data governance policy, which is critical to the success of any of these interoperability systems. Because things like who owns the data, how are we going to be able to share that data, who should have access to which elements and which pieces of data. All of these, again, are complex issues which should be addressed from the beginning as you're starting to look at the technical design of the system. So you should also be looking at the data governance policy around that. Next steps, please. And then our second recommendation is really talking very much around following this very iterative phased approach to develop, to implement, and to keep testing. So you base it on a maturity model. So that has a number of elements. So one is really expanding the existing DHIS, but also looking at the other elements. So looking at the facility data, looking at community data, and then looking at how you're going to develop a back-end data system to store all of that. And all of these pieces don't necessarily follow on each other. These could be parallel streams. And another key recommendation is also to integrate and align with existing projects and existing initiatives where they are, to be able to really build this out in a very iterative approach. Next slide. I think we're at the end. Yeah, there we go. So thank you very much, and I'm going to hand back to Vimla now.
Thank you very much, Linda, and thank you to all our speakers. We're now in the Q&A section of this meeting, so I invite you to ask your questions or raise your hands, and we'd like to have some discussion. Thank you. Any points for clarity or elaboration? Let us know. We have the speakers on hand. Sandhya, would you like to raise any points and then open that for discussion, perhaps?
Vimla, thank you. I actually was hoping we would get some questions, concerns raised. We also have many senior managers on the call, including our dear provincial coordinators. So it would really help if we could maybe get some comments and questions going. I see a note here that Vicky has her hand up.
Thank you, Sandhya. Vicky, please go ahead. Hi, Vicky. Vicky, can you hear us?
Sorry, yes, I was sorry. Thank you very much. I'm speaking as civil society, the South African Non-Communicable Diseases Alliance, and I want to thank everybody for their presentations and for the Better Health Project for this fine presentation, which would seem to support our requests and our concerns as people living with non-communicable disease and those at risk. So for us, our great question would be, how do we move forward in this, in a collaborative co-production, in a way that actually goes down to a district level? And that's a big question, but how do we co-produce better than we're doing it at the moment? And how do we change the way that we work? So there's a whole lot in that, but it's a real gratitude. I feel that I am now ready to retire. Everything that I've been moaning about and asking for has been highlighted. And so thank you very much. Over to you.
Thank you very much, Vicky. Joseph, we're going to take two to three questions and then we respond. Joseph, please go ahead.
Thank you, Vimla. And maybe I should start by thanking the Better Health Program South Africa for the support, and for to the Department of Health for putting this together, and also for the colleagues who have come in from the provinces, and our friends and partners from the non-state actors, Vicky and team from the NCD Alliance. Thank you so much. I joined in late, apologies, but I just wanted to highlight two issues. One, and it's a question really, around investment, around improving surveillance for NCDs. As you may notice, and I'm happy that somebody compared the status of our NCD surveillance with the HIV and the TB. And basically, when you look at them, it all boils down to investing into those surveillance systems. That's where they are now. So the question I would ask, and to Sandhya and all of us, is how do you see our investing more to improve because it all boils down to investment of more resources, both personnel and finances, to improve surveillance, right from data collection to collation, all the way to interpretation, and even interpretation and translation for policy users to be able, for policymakers to be able to use this data. And it boils down to right where the data is collected, because sometimes we overinvest on at the top and forget where the data is sourced from. That is where the investment starts. So I don't know what you would say about how do we move ahead in investing right there where the data is collected to empower the facility themselves to collect quality data so that improves the quality as it goes up. And of course, Vicky has mentioned the other thing is how do we carry the people living that NCDs along as co-producers of quality data along? What role do they have as we go along? Thank you.
Thank you very much, Joseph. Are there any other questions at this point? Sandhya, would you like to respond in the meantime, or are there any other speakers that would like to respond?
Yes, thank you, Vimla. I would like to respond, but I would also like, before I respond, to ask whether any of my, firstly, my national colleagues on the call would like to make any comments. And also, I would definitely encourage the people on the ground, our dear provincial coordinators who are dealing with these matters on a daily basis, to also make some comments, and then I will definitely make some comments. My national colleague.
Sandhya, my hand is also up. I don't know whether you saw it. Maybe it's because it's written Slindo Uhle. Maybe that's the reason.
It's Cindy. Cindy, could you introduce yourself, please, first?
Okay, it's not Cindy. Good afternoon, everybody, and sorry for joining late as well. It's Sarah Kumete. I'm the Director for Non-Communicable Diseases in Mpumalanga Province. Unfortunately, I don't know what happened. I missed this meeting. If it wasn't for Cindy, I would have just learned about it later on, you know, because I just totally forgot somehow. And then she just reminded me right now. I just found the presentation on data, which I think Joseph has indicated, you know, some of the concerns and the maybe raising even the, you know, the questions around the issue of surveillance, in particular that we have been really, you know, struggling over the years. And from the look of things, my thinking, you know, is that we definitely cannot see anything, you know, moving on if we can think of DHIS, because we have been, you know, fighting and, you know, for years, over the years, they would be taking out whatever that we were putting, and it was not, because it was an aggregated kind of information. It was not, it cannot tell you how many people do you have for diabetes. You cannot have, it cannot give you a register that will indicate even the control rate or whatever, or defaulter rate or whatever. So I think the best, you know, system that if it is, you know, because you are, you know, this presentation came at the right time, that I'm also, as a province, we are busy looking at having a system, because we realize that there is nothing that is happening that we can use basically around NCD when it comes to information. So we were trying to think even in terms of system, you know, developing a system that we can utilize to do that. So if this is something that can be done from national, I think this is a good one. But I think my contribution will be like, we, you know, DHIS didn't seem to be a way to go. We've been trying, we failed. Let us look at the tired.net, whether it's a similar system or we upgrade that to also, you know, collect the similar information, so that we get everything. Because when you look at that, and then you realize that most of the people who are on ARVs, they start to develop hypertension and diabetes. So they are there. So it will be better to use something that will be an integrated kind of a system that include even those that are on ARVs, and also those now who are having other comorbidities, you know, whilst they are on the very same ARVs. That is my contribution. I didn't get the gist of the other things, but this one, I think, for me, it will be able to help me, because I'm really looking forward to present something on Wednesday to my principal around the issue of what is it that we need to do for NCD. As we are talking about the issue of COVID, we have seen a lot of, in our province, 74% of the people that died, they died because of complication from diabetes and hypertension. So now, I mean, even if we can be looking at that, then what is it that we need to do? And some of them, they didn't even know their status. So now we need to integrate so many things. So having a strategy that will integrate all these factors, and then we look at what is it that we can do regarding those elements. So that is what we are planning as a province. So this one can help as well. Thank you.
Thank you very much, Bilkis.
Thank you, Vamla, and thank you to all of the presenters for very interesting presentations that were made. I would like specifically to talk to the data, the NCD surveillance systems that were spoken about, and recommendations made towards developing a dedicated system for NCD surveillance. You know, although this would be great to have an NCD specific surveillance system, by encouraging this, what we'll be doing is encouraging a disease-centric surveillance system, and that's not exactly what we're wanting. We want to treat the patient as a whole. And remember, there are many patients out there who have both communicable and non-communicable diseases. So ideally, what we should be looking at is adapting the tier.net system to include data elements for collection of NCD data. And if we use that system that is already implemented so widely in South Africa, and if we use that system, we would be able to get better quality data and more appropriate data that can be used then towards program planning in terms of developing policy. So, you know, at the moment, we do not have the funding, we do not have conditional grant funding for developing a separate system for NCD surveillance. So ideally, we should look at what has already been being used around the country and use that system to incorporate NCD data. Thank you.
Thank you very much, Bilkis. Are there any other questions before I move on to Sandhya?
Maybe I can comment. Is Deb?
It's Deb.
Hi.
Deb, please go
Can you
ahead.
hear me? Can you hear
Yes,
me?
we can.
Yes.
Hi,
We
good
can.
afternoon. Good afternoon. So just to mention that I fully concur with my previous speaker that, you know, the days of standalone systems are gone because of the multimorbidities. And in fact, actually, we are using tier.net in one of the clinic in Johannesburg successfully for last more than a year, and incorporating the multimorbidity data in the tier.net, and we actually producing results out of it, and we are now finalizing our publication for that. So for me, that's the easier thing to do. We have a paper-based system we downloaded in from the tier.net, which we then complete it. When the system works, we directly enroll it. When it doesn't work, we write it in a paper form, which we introduced in the clinic. And from there, when the system come live, then we actually captured it. But now, more or less, we are live into the tier.net. So I fully concur with my previous speaker. That's the way to go. And I think it helps us definitely. And actually, we are planning to roll it out now in one of the clinic in Swane in the same vein. Thank you.
Thank you very much. Are there any questions on the other presentations on social and behavioral change communication and the multi-sectoral and standalone strategies as well?
Just a comment from myself.
Yes.
I don't see my hand here going up. It's Shelley speaking from Northwest.
Okay, please go ahead, dear.
Okay, thank you so much. Yeah, I'm just looking into the issue of data and how to collect it, and seeing that there's a system that CCMDD is using, the sync. It's called the sync. I just want to find out maybe how can we, like Bill used to saying that you cannot come up with lots and lots of systems. We've got tired.net, and then we've got CCMDD that's capturing also, and it also deals with chronic diseases there. How can we synergize all these things to get what we want. It's just a recommendation, just to say that look also into the CCMDD model, the sync especially, to say it out. The sync as a way in that we can have the data that we wish to have. Thank you.
Thank you very much, Shirley. Rabone?
Thank you very much, Vilma, and thanks to all the presenters for rich information that you have given us around how programs, what is happening with some of the programs that are actually happening at the national level, and even what is happening at provincial level, and the recommendations that you have brought forth. I just want to comment on the evaluation of the SBCC strategy that was done, that we really appreciate efforts that went into doing the evaluation. And perhaps with regards to the recommendations around M&E, should also look at how best could this be done, because that is one of our key challenges at the national level, in terms of really coming up with an M&E framework and developing it and really implementing it. The second issue that I want to talk about is with regard to the discussion that seems to be very key around the use of maybe Tire.net. And I want to find out, if we so much talk about the Tire.net, what about the DHIS? I know that DHIS has not worked for us in the past, and we're all struggling where a lot of indicators, rather they want to cut rather than add any indicators. So it has not worked for all of us. I think that's why HIV, AIDS and TB program also developed a different system of Tire.net. But if we're thinking, because we are really thinking around that, I hear from the discussion, but what about patients that will have chronic diseases and not be patients that have other, like HIV and AIDS and TB? Because I'm thinking that is what is captured. Those are the patients that are captured on the DHIS. And do we really think it's a good idea to go through that route? Because when Tire.net was developed in the clinics, you'll find that they even appointed a dedicated data, what do we call them, data capturers in the clinic, specific clinic, to capture that data. So will they be willing to also capture other data that is not HIV, AIDS, and TB related? And are we now starting to render DHIS useless by doing that? I just want to find out what is our thinking around, specifically even for patients that will not be candidates for Tire.net. Thank you, Chair. Bye.
Thank you very much, Rabone. I think in the interest of time, we need to respond to the various comments and questions that have been made. Firstly, can I just ask whether the speakers, Claire or Linda, would like to respond on the Tire.net issue, just for clarity, and then move on to Sandhya.
Hi, this is Linda. Yeah, so very good points raised. And just in terms of the last speaker, in terms of utilizing Tire.net for people who don't have HIV and TB, I think, you know, when we looked at that patient journey, in the sense that the way that the patient progresses through the clinic, it follows a very similar model, in the sense of, you know, they arrive, they get registered. So you could potentially register someone within Tire.net and then only collect data elements relating to NCDs. It would obviously involve, you know, a significant amount of work to extend Tire.net to be able to do that, but it's still far less work than actually developing and creating a brand new system from scratch. And you know, I think also one of the reasons why Tire.net has been successful is because it does use that back entry data model. And it also is able to be used in a wide variety of environments, which are very hugely within South Africa. So, you know, from within pretty well connected, well resourced urban settings to low resource settings where there isn't connectivity at all, but data might be collected onto a desktop machine and then put onto a USB stick and sent to the next level where it can then actually be captured. And I think it's all of those aspects of that system that actually make it potentially very useful to be extended, and certainly to understand and learn from those lessons as well. Thank you.
Thanks very much, Linda. Can we move on then to Sandhya?
Well, firstly, thank you very much to the Better Health Program. The comprehensive reports that were presented are highly commendable and definitely or must be used and considered very carefully by the department in terms of integration into the NSP, which we have not yet finalized. With regard to specific questions, Vamla, I definitely I hear the frustration of both colleagues from on the ground, our provincial coordinators, as well as civil society, and we share that frustration. We believe that for far too long we have been struggling to prioritize NCDs, noting that it is a key cause of death and disability in this country. And unfortunately, due to certain funding models which favored, donor funding, global funds, and other sources of overseas funding, certain programs have progressed far ahead of us. But I think the important thing for us to do now is look at what are the lessons we can learn, not only in terms of the health system strengthening, but how those programs were then able to locate themselves, maybe not officially so, but within integrated person-centered care. I'm not sure if you go back into those programs, you will see that they make mention of it. However, they do position their programs within issues of human rights and equity. And underlying many of the successes of these programs has been really good, solid, credible data. And I think from what you've heard from my colleagues now is that one of the most pressing priorities that we are all facing is that because we don't have credible data and data sources, we have been struggling to make the case for NCDs. And we know that if you go to Treasury today to present a business case, you've got to have solid data. And unfortunately, we've become caught in a cycle of disadvantage where, because we didn't have systems for proper surveillance, we've never been able to make this case. So it's really encouraging that we've had reports presented which highlight all the sources of the frustration that both programs as well as civil society have been expressing. And I would really like to, for those programs, for those provinces that are engaging their provinces now around data, please rather let's use what is existing and look at how we can integrate what we want into existing systems. And I think that Linda's made some very clear proposals about where we start looking at an incremental approach of integrating what we have, strengthening that, testing it out, and then expanding on it. And I think that we do have a project at the moment where we will be adopting this approach. But let us not forget what is working. And I think we've heard from Deb about their initiatives to integrate NCD data into tier.net. And we've also heard a significant mention made of the attempts in the Western Cape to integrate NCD data into their data center. ultimately, all of us want not only to ensure implementation of appropriate care, but we want to ensure implementation of quality care, and that this must be reflected in the outcomes. Hence, we need to be able to show, to reflect the journey in terms of data from the time a patient is identified at risk throughout that journey, from diagnosis, treatment, compliance, adherence, as well as then their outcomes in terms of control. And unless we have this, we are never going to be able to show what the value interventions have. We're never going to be able to demonstrate that unless those interventions are put in place, we are never going to be able to afford, for example, the NHI. If, for example, we are never going to be able to reduce complications of diabetes, our hospitals are going to be flooded with patients who require care for complications. Those patients are never going to be able to go back to work, to be financially independent, and to be able to contribute to the economy. But all of this hinges on effective and efficient data systems which are integrated. So as much as the reports have highlighted critical issues, the proposals around how we go about implementing multi-sectoral approaches, once again, that also depended on what kind of data we have in place. And we have struggled to demonstrate the need for NCDs to adopt similar structures as has been done for HIV and AIDS. And I think we now have the opportunity of the NSP to demonstrate that. We've also struggled to show policy cohesion within the department in terms of integration with existing programs. I think that we are encouraging it, we are seeing signs of it, but this has to be taken to scale, not only at a national level, but the integration into other programs, whether it's women's health, child health, health promotion, medicines. It has to be demonstrated at a national level, and that needs to be then moved down to the provincial level. And policy cohesion is absolutely critical. So programs have got to show understanding of how their programs are supported by ensuring integration with NCDs. If we're looking at, for example, enhancing maternal health, we've got to show how our guidelines on hypertension will support them. So unless there is no acknowledgement of this, we're going to be struggling. And of course, I think we've all heard right from the outset, we've understood the importance of prevention. And thank you very much for sharing the interventions that should be addressing, enhancing our preventative strategies. Those may not be reflected in detail in the NSP, but I think Ruboni and the health promotion team will definitely use those interventions to strengthen their existing strategies. So we will be circulating these, but I think what has been very important is for us to interrogate the recommendations. And I want to strongly recommend that the national team ensures that the summaries are circulated to our provincial colleagues, and that we create a platform for interrogation of these and how they can be used to improve our cohesion and service delivery at a district level and strengthening district development plans. Vimla, I'll stop there unless there are any further comments from my colleagues.
Thank you very much, Sandhya. I think we've run out of time, unfortunately. I just want to reiterate that the full reports and the summaries will be available. We can send them through to participants on this at this meeting. We'll send them immediately after this meeting electronically, but thereafter we'll look at greater or wider distribution and dissemination, and perhaps also the possibility of having more detailed discussions on specific issues that pertain to the reports in the future. So Sandhya, I'm just going to hand back to you to thank everybody, and we need to close the meeting. Thanks, Sandhya.
Thanks, Vamla. I'm sure it would have been in order if you also did it. I understand the time constraints. I want to firstly thank BHP Better Health Program South Africa, the UK Prosperity Fund, as well as the development officers and the delivery partner, Mott MacDonald, for supporting the NCD agenda in South Africa. I think we are indeed in a very fortunate position. I would also, I think, equally important, not only our colleagues from the provinces, but our partners, including Joseph and WHO, Vicky and the full team from civil society, and the other partners who are on board at the moment, including the provinces, Deb and other teams. I feel confident that we are on the right track to ensuring that the NSP is responsive to the needs of the people of South Africa within a rights and equitable based model. And I think that the reports presented today were excellent, comprehensive, and will make that happen. So thank you very much to all the authors of the report and the partners and my colleagues on the ground. Thank you very much, Vamla.
Thank you. Thank you, everybody. Thank you for your attendance and participation. Goodbye.
Thank you, Val. Thank you, Sandhya. Thank you all. Bye.
Bye-bye.